There we go. Thank you. So here are my disclosures. And my objectives really to talk about female sexual function and dysfunction, to really talk about hypoactive sexual desire disorder, which is the most prevalent sexual dysfunction for women of all ages, to talk about its impact on quality of life and how you can address, assess, diagnose very quickly this condition in your patients, and to excitedly talk about some of the new pharmacologic options that are approved in the United States. Well, in order to really get a sense of sexuality, I think it's important to put a face, or at least a name, to the condition and think about Sylvia as we go through my talk. Now, Sylvia is 36, and she presents to your office for her annual exam, and she's been married for 12 years, has an 8-year-old healthy daughter, and as part of her comprehensive history, you, of course, have inquired about any sexual concerns, and she reports actually decreased sexual desire. So before we talk about what sexual dysfunction is, I think it's helpful to have a sense of what normal sexual function is, because you need to understand the sexual response before you think about what the problems are. So what do our patients think about normal? Well, they're not really looking at statistical norms. They're not reading the literature. They see what our culture tells them is normal, and that's how they see it. So they walk into your office and they expect you to know what culturally the norms are for sexuality. Well, historically, the norms for understanding female sexuality really have been that it's underground. It's been given very little attention, little acknowledgement. Research and treatments for sexual dysfunction really have lagged well behind those of male sexual dysfunction. We have many drugs to treat male sexual dysfunction, like erectile dysfunction. So we can date some of this back to the Victorian era, when, despite all the beautiful art that I have seen in Vienna, when it was discovered that female orgasm was irrelevant for conception, female sexuality essentially went underground. It was considered unimportant, irrelevant, and therefore to be ignored. So we fast forward to 2019, and we say, well, finally, women's sexuality has hit prime time. We see it discussed in every newspaper, news magazine, it's on television, but really it has not quite hit prime time. We have not reached an equivalence in our understanding of female sexuality and certainly in treatments for female sexual dysfunction. We do have some models for understanding sexual function. Actually, could somebody put the timer on here, because it says 15 minutes forever. So I have no idea how long I'm taking here. But let's talk about the human sexual response. So Masters and Johnson in the United States were the first two to empirically look at the physiology of the sexual response. And based on studying men and women who came into their lab, they said there is an invariant linear progression of how the sexual response works in both men and women, beginning with excitation, where the body becomes aroused by some psychophysiologic response or response to an erotic stimulus. So for men, there's erections. For women, there's vaginal lubrication, vaginal swelling. With enough sexual excitation, with appropriate sexual excitation and no interruption, the body reaches a peak level called plateau just before orgasm, and orgasm is the release of all sexual tension, usually experienced as pleasurable. And then the body moves to an unstimulated state called resolution. In the 1970s, Helen Singer Kaplan, a psychiatrist, said, well, there's something really important missing in this sexual response, because really the most important sexual organ is the brain. And so she incorporated the concept of desire. And so now we have desire, arousal, and orgasm. Rosemary Basson in the 1990s, early 2000s said, well, this linear progression may not really reflect how men or women really experience a sexual response, and that linear progression starting with desire may not always be the order of things, and that many women, particularly, will begin their sexual encounters from a position of sexual neutrality. That is, they're not particularly interested or hungry for sex, but they know that it will create emotional intimacy with their partner, or they read in a magazine that it burns 500 calories, or they know that their partner will be very happy if they initiate. So they will either be responsive or initiate on their own, despite not really having much interest. And then with appropriate stimulation, arousal kicks in, and then desire kicks in. And that would be sort of responsive desire and considered normal. But women who have hypoactive sexual desire disorder, that experience of, this feels great, why don't we do this more often, never happens. Okay, so regardless of spontaneous or responsive, it doesn't happen. And it's important to think about this from a biopsychosocial perspective. Now, I say that not to, put fear into you that this is complicated and takes too long, really to reflect the fact that if you understand the biopsychosocial components that go into sexuality, it helps you identify which problems are occurring, which will then guide your treatment approach. So for many women, for example, psychological factors can either contribute to healthy or dysfunctional sexuality, depression, anxiety, performance anxiety. Interpersonal factors clearly are related to sexual desire, right? You can have all the biologic urge in the world to be sexual, but if you're mad at your partner or if you don't like him or her that much, then you're not going to have much interest. Then we have sociocultural factors, right? Religious, cultural factors that can contribute to healthy sexual function or certainly dysfunctional sexuality. And finally, we have biologic factors. We know that physical health is clearly important for healthy sexual function, but we also have to think about neurobiology and, as Professor Genesani talked about, hormones. All of those contribute to healthy or dysfunctional sexuality, and we look at this from a biopsychosocial perspective, which I'll talk a little bit more about when I talk about how it relates to depression. So there are essentially 4 general categories of sexual dysfunction in women. We have decreased desire, diminished cognitive or genital sexual arousal, problems with orgasm, and then genital pain with sexual activity, and for our postmenopausal women, genitourinary syndrome of menopause, or as Professor Genesani talked about, vulvovaginal atrophy can certainly result in pain with sexual activity. So when we think about the most prevalent sexual dysfunction, it's hypoactive sexual desire disorder. It would be defined as, according to the International Society for the Study of Women's Sexual Health, any of the following for at least 6 months. And in fact, most of the women that are coming into your office have been suffering from this condition for a lot longer than 6 months, but have really felt either invisible or they had no place to turn. So it's the lack of motivation for sexual activity that's manifested either by reduced spontaneous desire, spontaneous sexual thoughts, dreams, feeling horny, if you will, or reduced or absent responsive desire to erotic cues, or the inability to maintain desire throughout a sexual encounter. This can lead to avoidance, going to bed at a different time, and the experience of personal distress is key to the diagnosis, and women will describe this as feeling frustrated or essentially grief-stricken, incompetent. They feel a lot of loss, sorrow, and certainly they're worried. So I did this survey a few years ago looking at what the impact was of low sexual desire. And when I said earlier that it impacts quality of life and how important it is to women's lives, it is critically important well beyond the bedroom. We know that with low sexual desire, it impacts their body image. Women feel less sexual, they feel less attractive, and it's not that women who have poor body image will report they have low sexual desire. You would expect that. This is the other way around, that by virtue of having lost their sexual desire, they've lost their sense of femininity and their sense of being attractive. They certainly have lost their sense of self-confidence. 51% said by virtue of having low sexual desire, they didn't feel as confident outside the bedroom. And it absolutely impacted their relationships. 67% said they felt less connected to their partner. 35% said communication had been interrupted by virtue of low sexual desire, and 35% of women were worried that their partner was going to cheat. So think about this from a clinical adage, right? Here's what we know clinically. When sex is good, it's good. It adds some value to a relationship, about 15 to 20% added value. But when sex is bad or non-existent, it is inordinately powerful, draining that relationship more like 50 to 70%, right? So bad sex does way more to subvert an otherwise good relationship than good sex can save an average one. Think about your own lives, right? Many of you are probably in great relationships now, but maybe once upon a time you were in another relationship. And maybe in that relationship the sex was really great, but you're not with that partner anymore. Well, why is that? Well, if you were in the United States and it was 2016, you might have found out who they voted for, and that's the end of that. But there are many reasons why if there aren't things outside the bedroom that will keep you together, no matter how good the sex, it's not going to last. But what I see clinically are women who come into my office every day and say, everything else in my relationship is good. We're best friends, we have shared values, we enjoy each other's company, we're best friends. But if I don't fix my sexual desire problem, I don't think my relationship's going to survive this. And that's what I mean by the imbalance. So desire to me is the new depression, right? And this is not that you're supposed to have desire for somebody wearing these 1980s clothes, but if anybody old enough to remember, this is what the heyday of 1980s fashion was, at least in the United States. But I want you to think about desire as the new depression. So in the mid-80s, before we had easy-to-prescribe antidepressants, depression was seen as all psychological and all in your head, right? Go see a psychologist like me. But once we had easy-to-prescribe serotonin reuptake inhibitors and generalists could prescribe, all of a sudden, depression was seen as a true medical condition, as it was accepted as a medical condition with biologic underpinnings, and it was easily seen to be treated by physicians. Now, we fast forward to 2019, and it's the same. So hypoactive sexual desire disorder has biologic underpinnings, and now we have two treatment options that allow you to not just say, oh, it's all in your head, but to recognize there are neurobiologic underpinnings that can be treated. So it allows you to take that on into your practice and ask your patients, do you have any sexual concerns? So when we think about back to that, the concept of biopsychosocial, think about sexual desire from essentially a tipping point, right? There's a balance. And what we want when we want desire is for the scales to tip towards excitation, where we have physiologic organic factors and we have psychological factors, all that will tip us towards excitation. And on the right-hand side, we have serotonin, opioids, endocannabinoids that will create inhibition. And to be fair, we don't want excitation all the time, right? As a society, we would get nothing done if we were excited and wanting to be sexual all the time. So we need some inhibition, but when we want excitation, we really want to promote these factors on the left that will create excitation. So on the psychological part, intimacy, shared values, romance, all will push towards excitation, but certainly dopamine, oxytocin, melanocortins all push towards excitation. And surprisingly, serotonin inhibits. So any of you who prescribe serotonin reuptake inhibitors will know that that can be inhibitor to sexual desire. So as our current treatments, we have psychotherapy, which I certainly do, pharmacological therapies, and sometimes combination. And treatment should be determined by etiology. And I need you to know that in the absence of you addressing their sexual concerns, women are going out there and doing God knows what, trying to find treatments, because we know that they will go to newspapers, the backs of magazines, and certainly to the internet. When we do psychotherapy, I just wanted to give you a sense of here's what I would do in a psychotherapy session. It's really about cognitive restructuring, and that can work for many women, but for many women who have that biologic underpinning, no amount of great psychotherapy is going to address that biologic concern. Similarly with depression. Cognitive behavior therapy works very nicely for some people who have depression, but sometimes you need that pharmacologic option to shift the neurotransmitters. So here we have our two pharmacologic options that are approved in the United States for hypoactive sexual desire disorder. We have Flibanserin and Bremelanotide just approved, and one of the reasons I'm here today is because it's so exciting that we have a second option. So just thinking in terms of neurotransmitters and the central regulation of desire and arousal, they are very intricately combined. And we know that really anything that will lead towards more dopamine production, certainly in the prefrontal cortex, is going to be important for desire, and things that can inhibit would be things that would promote serotonin. Hormones are clearly involved, but certainly the neurotransmitters are going to be key. So let's talk first about flibanserin, because it was approved in 2015. It is not the female Viagra that it has been labeled to be. But its proposed mechanism of action is that it's a mixed postsynaptic 5-HT1A agonist and 2A antagonist, essentially promoting dopamine and decreasing serotonin. In its phase 3 clinical trials, it was approved in 2015, not without some controversy, for acquired generalized HSDD in premenopausal women. So there were 3 pivotal trials, 24 weeks, with 2 primary endpoints, looking at satisfying sexual events and desire, and looking at decrease in distress. And I have to say that we have moved our understanding of sexual desire in women so that even the FDA has changed what they consider the primary endpoint from events, which are very downstream for women and desire. It's not about how often they have sex, it's whether they want to have sex. And so moving forward, we now understand that desire is more key. And in terms of adverse events, the most common were dizziness, somnolence, nausea, fatigue, insomnia, and dry mouth. What was interesting and very controversial about flibanserin was that it was originally, it still has a REMS, a boxed warning and a REMS, risk evaluation mitigation strategy, that initially prohibited all alcohol use. And now, as of April, or August 2019, they have changed the labeling so that it's not that it's contraindicated, it is that you must stop drinking alcohol 2 hours before you take your bedtime dose. It is dosed at bedtime. It is an oral medication. It's 100 milligrams. You take it every night at bedtime. And so there are still some warnings and precautions. It can't be used with CYP3A4 inhibitors, but the warning with alcohol is now changed slightly. And then we come to Bremelanotide, which is, I'm going to make that build it. It is really exciting because it was approved in June 2019, and it is also for acquired generalized HSDD in premenopausal women. And BMT is how you can shorten it. Vyleesi, it's its brand name. It's a novel cyclic 7-amino acid melanocortin receptor agonist. And what's interesting is that it's used as an EpiPen, so it's a simple auto-inject, and you can inject it either into your thigh or into your stomach. And you inject it about 45 minutes before your anticipated sexual event. But somebody asked me just recently, well, 45 minutes, that's not very much time. It's not 45 minutes, you only have 45 minutes before, and then it lasts about 16 hours. Okay, so you have plenty of time. So here's its proposed mechanism of action. Again, with the melanocortin receptor agonist, it works to promote dopamine, which we know is key to being responsive to sexual cues. And again, very effective in our premenopausal population. So here was the clinical trials. The FDA requires 2 identical pivotal trials, and over 1,200 women were included. It was a 24-week placebo-controlled double-blind with Bremelanotide of 1.75 milligrams versus placebo. And again, since we have learned how to better evaluate desire in women, the key endpoints the primary endpoints were the desire of the female sexual function index and a change in distress. In order to meet the criteria of having a disorder, you have to be distressed. And then we looked at satisfying sexual events. Then women were invited to enroll in a 52-week open label, so double-blind, and then they could go into a year-long open label. So women were initially in a 4-week single-blind placebo-controlled run-in. So all women got the placebo. And at that point, they were then randomized to the double blind, which is such a fascinating design. I think it should all be done this way, so that women then became their own baseline, so their placebo response became the baseline for which the treatment effect was compared. Okay, we didn't exclude women who had a placebo response. We included them, and that became their baseline. And then they had their placebo versus treatment for 24 weeks. Then they were invited into the 52-week open label. So you can see from the results that there was a statistically significant improvement in desire for the bremelanotide group versus placebo in both clinical trials, and a significant reduction in distress in both the parallel trials, okay, compared to placebo. And then when we looked at who is a responder and whether this had clinical meaningfulness, because it's one thing to have statistical meaning, but what about clinical meaningfulness? So women were asked, compared at the end of the trial, compared with the start of the study, to what degree do you think you benefited from taking the study drug? And so you were anchored to that as a responder. So 5 or greater meant you had some response to greater response. And you can see that the bremelanotide group, about 60% were responders compared to 35% in the placebo, which again shows a significant effect. When you can show above and beyond, when a CNS drug is always going to have a placebo response, usually about 30 to 40%, and you show consistently an improvement above and beyond that placebo response, you know you have a treatment that works. Similarly, as you get to a more strict criteria for that response of how impactful it was, at every point along the way, the bremelanotide group had a statistically significant greater response than placebo. In terms of safety, it has a very nice safety profile. Most of the adverse events were mild to moderate in nature. The biggest side effect was nausea. About 40% of women reported some nausea. But I will tell you, it was mild to moderate. Most of it happened once or was transient, and if it lasted, it was about an hour. Of those 40% who had nausea, only 8% dropped out of the trial because of it, so 92% stayed in. So about 18% compared to placebo of 2% dropped out of the trial altogether. The only contraindication is uncontrolled hypertension and known cardiovascular disease, no interaction with alcohol. So back to Sylvia for a second. She is 36 and she presents to your office. What are you going to do? You're going to give her this screener. This is in the public domain. This you can put in your electronic medical record. It will get you it is a validated tool for screening and diagnosis. If she answers yes to the first 4, which in fact she did, then you can look at all the factors in A through G, does all the work for you, to figure out what are the factors that might be contributing to her loss of desire, and are they better accounted for than the fact that she has HSDD? It doesn't matter, it doesn't mean that she doesn't have HSDD if she says yes to any of them. It just gives you a point of discussion. So, for example, Sylvia, in fact, has some depression. She had been, 10 years ago, had a major depression, put on an SSRI, and had been well managed with no sexual side effects. But 3 years ago, she started to experience her loss of desire. So would that mean that she doesn't have HSDD because she's on an SSRI? Well, she had already been on the SSRI, had no sexual side effects. So that's not the reason why she had this HSDD. So does she have HSDD? Well, I would vote yes. Is it better accounted for by other factors? Probably not. And would you treat her? Yes. How would you treat her? Now you have 2 options. You can give her a chronic dosing, or you can now give her the on-demand auto-inject of bremelanotide. So I just want to end by saying, I know you're already doing this, but please, in order to get women addressed, this is 1 in 10. The prevalence of HSDD is 1 in 10 women. Okay? And in the largest survey of US, 31,581 women, 1 in 10 met the criteria for hypoactive sexual desire disorder. So if your patients don't have it, we're not asking. So use a normalizing statement, open-ended. Most of my patients have some sexual concerns. What concerns do you have? Instead of putting your hand on the door, you don't have any sexual questions, do you? legitimize the discussion, try and sit down when you have that conversation. Practice using sexual terminology. You know how many gynecologists in my practice can talk about smelly discharge, but they cannot talk about sex. So please be comfortable using sexual terms, ask open-ended questions. Sexuality is important for overall health, quality of life. I can only reiterate what Professor Genesani said. There are safe and effective treatments. Please ask. You can't treat a problem if you don't know it exists. Thank you for letting me talk today.